Hello, good afternoon, our dear guests and members and interested in this important lecture. I would like to say the society and those guests coming from India, our instructors, welcome. And I would like to thank Max for sponsoring us, for giving us such very nice opportunity. This is a dual hybrid presentation in person as well as virtual. There are 150 people are waiting on virtual now. I think people are coming soon. So I would like to thank also Yetena Weg for giving us the digital platform, which has been giving us for the last 2 to 3 years. And today we'll have a mixture of presentation, adult cardiology, pediatric cardiology, and cardiac surgery, which is very beautiful in cardiac part. So the first presenter is Dr. Bekele. I don't think he needs very much introduction, but for those of us who don't know him, maybe abroad, and Dr. Bekele is a senior interventional cardiologist, associate professor in Addis Ababa University. He has been a founder in Gambia Hospital, Bahar Dar. Then he has been a founder in an cardiac hospital for 10 years. They have done a lot, very important intervention and cardiovascular service in the nation, where they start first Cath Lab in private. Then he has done a lot of papers published, and he was our very nice instructor, and he made us to be cardiologists without any, and he's an icon to be hard worker. I don't know, someone will be like him. Maybe in the middle of the night, he'll be there. So this is a very nice thing to have him. So no one is better than to present PCI in Ethiopia, especially primary PCI, where it's difficult in third world, where he has been in journey from beginning to till now. Currently he's working at Addis Ababa University as well as his own private hospital, Gesund in Cath Lab sites. So it is my honor and a pleasure to call my instructor, Dr. Bekele, to present. Please, Dr. Bekele.
Thank you very much, Dr. Kefelegn, for a very warming introduction. I don't think I deserve all those issues. Thank you very much. Anyway, today, the topic of my talk is the challenges of PCI in Ethiopia, with little emphasis to primary PCI. Well, I will be dealing with our particularities. What are the particular challenges we are confronted with? That's the most important aspect. And for the obvious reason, every issue, everything is tied up with our economic circumstances. So I think each of you should bear with me for being so vocal in the social and economic aspects only. When PCI started, it wasn't smooth everywhere, but it was rather difficult to introduce PCI in places where there was no surgical backup. So then our slot started without any tangible surgical backup. So then I will be discussing on the issues that has happened all over the world, and subsequently how we extracted the information from elsewhere. So in the beginning, as PCI started, occurrence of adverse effects and leading to lesser outcomes was the most important issue. That was galvanized because of low institutional volume, inexperienced staff, and then the attainable requirement of immediate bypass surgery. Starting from the first 50 cases of Andreas Grusing, that problem was very vivid. Like in his publication in 1979, out of those 50 patients, 64, the success rate was just limited to 64. And there was a 6.4% frequency of MI, and some 14% of them required immediate surgery. And these problems, this issue was mainly because of two problems. One was abrupt visual occlusion. The other one was restenosis. Both of them were requiring a great deal of revascularization. But that was subsequently mitigated when stents, bare metal stents were innovated. You would remember the two studies, the two outstanding studies of stress and vein stent. Both of them have demonstrated the advantages of stent implantation over angioplasty. That was subsequently improved by the appearance of drug-eluting stents, improved technology, and at the same time, adjuvant pharmacology have revolutionized the situation, and then that has decreased the frequency of revascularization. And the most beautiful and outstanding data was from the Cleveland Clinic Foundation, whereby a reduction, a 10-fold reduction of requirement of immediate surgery, emergency surgery, was demonstrated between the years of 1992 and 2000. So the next question is, like the data in the Cleveland Foundation was with patients with existing surgical backup. So what about in situations of the absence of surgical backup? That was the next question. But similarly, the studies have shown improvement of the circumstances. Like, look at the p-values here. These are patients with surgical backup, comparing medical therapy with intervention. And the p-values are not that different. They really parallel, even in places where there was no surgical backup. So that was our stimulus to proceed with the procedure. And in America, because of this issue, not only the number of centers have increased over the years, at the same time, the number of procedures has also increased when places without surgical backup were allowed to do the procedure. And into 2012, some 26% of the PCI procedures were done in places without surgical backup, and in low volume centers already, having demonstrated the benefit I have shown you. And even, 49% of them were even being done in places whereby the annual volume was less than 400, 26% in places with less than 200. And out of 1,298 facilities, 33% were without surgical backup, and 65% of the annual volume by then overall was less than 200. What about the situation on our side? This is the data from Invasive Cardiac, the first 5 years. Coronary artery disease in frequency was second to only hypertension combined with hypertensive heart disease. Otherwise, every single diagnosis was having a frequency much lesser than coronary artery disease. That is not the only issue. We were being showered by patients with vivid evidences of clinical evidence of myocardial infarction. Patients who had unrecognized MI were presenting with heart failure, those with acute coronary syndrome, stable coronary artery disease, and the most unfortunate ones, The most unfortunate ones were presenting with malignant arrhythmia. So then for us, it was customary to attend days of patients with coronary artery disease, especially those presenting acutely. This is because our management, like the world, has passed some 5 paradigms of acute coronary syndrome management. But we were here. Just we were analyzing, we were taking vigorous hemodynamic look and analyzing arrhythmia. Otherwise, everything was limited to that. And that was the reason why our patients were dying one after the other. So this was the source of our commitment. And our commitment translated into practice because of Dr. Fukru. Dr. Fukru Maru is the most courageous individual who was able to bring in a Cath Lab. And I utilized that opportunity, and it was very astonishing for us to do the first angiogram. That was very marvelous at Addis Cardiac Hospital. And the next issue was to just consolidate our commitment for a seamless takeoff. That has happened. Subsequently, our determination was utilized as well to popularize the procedure across the country. And this was not without any problems. It was very difficult to convince patients. In most instances, our patients were nervous for 2 reasons. One, the primary performance of the procedure in the country was something to be doubted. And the second and very disappointing issue was the naively divergent information given by physicians who were provided the chance of making a second opinion. That was really very disappointing. The only ways to come through this was to do the procedures carefully and to solicit materials from abroad. That was being done again by Dr. Fukru. I was very much careful with the procedures, and then that was vivid with the publication of the first results of the first 5 years results, which were, containing 300 angiograms. Out of those cases, some 76% of them were having evidence of coronary artery disease of 300 angiograms, and 54% of them were having STEMI clinically. The rest, 33% were having NSTEMI, and then 20% were unstable angina. And the risk factor profile of our patients was quite similar to elsewhere, the West, for instance. The most frequent side risk factors were hypertension and dyslipidemia, followed by diabetes, and some just over 90% of our patients were having at least one risk factor. The results of our angiogram, 65% of them were having significant disease, and 24% were having no evidence of coronary artery disease, and 11% of them were having non-significant disease. To show you the frequency of a single multivasal variation, like single vasal disease dominated in that particular study in STEMI patients, as convincingly it's higher in frequency, whereas multivasal disease was dominating in NSTEMI and those with angina. This is because of existence of higher frequency of multivasal disease in the second 2 groups of patients. What did we do? In 35% of them, there was no action. These are the patients without evidence of disease and with non-significant disease. Out of 126 patients, 123 underwent stenting. That means 41%. And coronary bypass surgery was recommended in 23% of them. Shibikom is smiling because it's not happening today. That is why he smiles. Then, this is just the other way of putting things. These are the complications, like our success rate, TIMIS reflow was 92%. There was 1 stroke, 2 major bleeds, and 3 diseases. None of them occurred in the Cath Lab. There was 1 abrupt vessel occlusion that seemed to have happened clinically on the 2nd day, and then 1 retroperitoneal bleeding. Again, retroperitoneal bleeding does not kill today because our vascular surgeons are with us. And 1 of them just deteriorated in terms of cardiac status over the following 3-4 days. So what is the current status of coronary revascularization in Ethiopia in general? Now, the number of PCI centers has increased. 5-6 centers prevail in Addis alone, and 2 private hospitals, 1 charity, 1 public hospital are doing cardiac surgery. I don't know, I might be mistaken here. And we have again analyzed and published the first 197, the first 200 patients in Gizund Cardiac Center who underwent PCI over 2 years after its commencement. And then the frequency of clinical cases, like 56% of them were having STEMI, some 23% NSTEMI, and 31% were having chronic coronary disease. So the frequency of disease conditions really matches with the previous one. So totally, altogether, be it in the first 12 hours or so, emergency intervention was required in some 57% of cases. That is critically important. And as our center started, you know, some 70% of them were having single vessel intervention. Double vessel intervention was limited to 21%. Currently, that has, I think, grown up. Dr. Chala can comment on this. So, in order to show you some cases that may indicate our status, there was one of them was a 50-year-old male with type 2 diabetes, hypertension, and typical angina for 8 years, who presented with increased frequency of and the duration of chest pain. You know, he was having chest pain for 8 years. That is the most important issue. Look at the lesions. LAD is totally gone. And this is ramus intermediate. The intermediate branch is also having a tortoise segment with tight stenosis. This was the right one. The circumflex is not there at all. Yeah, very diffuse disease of relatively small circumflex. RCA, the PDA, it's totally beaded. Here is a significant lesion. Then following a PCI, at least we could help him. You know, the LAD was occluded with difficulty. And then we stented, we could stent that tortoise segment. And then we somehow dilated the right coronary artery. There is a great deal of tortuosity here. You know, we're very much afraid of even stents may not be delivered there. So then we dilated. He's doing well. Now it has been 3 months. The second case, a 78-year-old male with chronic kidney disease who presented with chest pain of 18 hours. while he was waiting for to decide, this is a Swedish guy. When he was waiting to decide, he developed aspirin-induced gastropathy, and he bled. We had to transfuse him, and subsequently, the angiogram is like this. No, it was following this angiogram when he was contemplating to decide, he developed the GI abnormality. Look at, this is a tight lesion. Then, you know, he couldn't go with this lesion all the way to Europe. We had to do the procedure. Now, one of the challenges we are confronted with is the absence of drugs like ticagrelor. You know, we opted to do the procedure. Indexing the Atlas trial, we decided to do the procedure with aspirin plus rivaroxaban, 2.5 milligrams twice a day. And subsequently, somebody brought him Brilinta. So this was the result. This is the second slide showing a beautiful lady. The next patient is a 61-year-old male without previous remarkable medical history. This is a diaspora from Ohio, I remember. And then it was very difficult. He presented with 3 hours of chest pain, and the LAD was not totally visible. Okay, look at this. Probably some dimple is visible in this view, but the ultimate result was like this. So, we're good. What about primary PCI? Yeah, as I have been trying to show you, the demand is huge. Like, for instance, altogether, over 14,000 patients are waiting for either open heart surgery, valve, congenital, bypass, or PCI in ጥቁር አንበሳ hospital alone. In ጥቁር አንበሳ hospital alone. So what are the challenges then that have limited our progress? First, limited access for the obvious reason. Cost of the procedures, lack of good dedicated insurance system, late presentation of a patient's, absence of well-informed, holistic, dedicated importers for consumers. These days, because of the scarcity of the foreign exchange, our importance, they attach, like for instance, they attach amoxicillin syrup or paracetamol syrup with clopidogrel. It might be somehow sensible to consider a statin or a beta blocker with clopidogrel or any of the other anti-platelet or anti-thrombotic agents. But this is the type of practice we have. I don't think our circumstances would enforce us to do this. It's because of lack of understanding of the problem we're in. Very limited availability of foreign exchange. Yeah, I'm probably the highest witness because I go through all the banks every day. The magnitude of the problem is not recognized by the respective government bodies. Does the Ministry of Health know this? Does the Ministry of Finance know this? Does the Ministry of Revenue know this? I think this is the task of all of us, particularly the society. We should take it up. We need to discuss with them. We earn the foreign money because of our personal contacts, like bank presidents, bank governors, for whom we have done these beautiful procedures, are the ones who are bending down. They even offer us USDs up to over 500,000 because these are the individuals who know the gravity of the problem. It's not because we acted towards their relatives. It is because they had a chance to know how important it is. I think this is very decisive. And poor public awareness. So each of us have contributed for the challenges, the problems. Delayed presentation, is it challenging us? Yes, it is. Like One of our patients, a 46-year-old male presenting with anterior chest pain 48 hours. This is proximal LAD flow of thrombus. We could do a very beautiful PCI, but that was beyond 48 hours. And he remained with ejection fraction of 35%. I have seen the echocardiogram Dr. Chala did a week ago. It's still 35. It started with 30. The increment is only 5% over 4 months. So this is really grave. A 70-year-old female, this is the other aspect of our challenge. A 70-year-old female with 6 hours of chest pain who developed a recurrent pulseless VTAC right on the spot of the emergency department of the first hospital she presented with. She was beautifully, repeatedly cardioverted from VF VTAC, but she was transferred to us 4 days later. That makes it strange. That makes it strange. And the result was like this. The LAD is not there. And we could do again good PCI. We also have documented, published evidences of the prevailing situations in our hospitals. This is a data done by Dr. Lamlam. She was doing her PhD between the hospitals of Tukurambasa, St. Paul's, and Gizund. By the way, when she collected 148 cases in Tukurambasa and St. Paul combined, she could collect 182 in Gizund alone. And in this particular study, you know, the number of individuals using ambulance is quite limited, and the understanding of patients was quite poor. And that was rather vivid here. Like large majority of the patients, this orange bar indicates that they were not sure of their symptoms. Large majority of the patients were having poor understanding of the alarming circumstances they were in. So then, what are the efforts being done? The efforts being done from the diaspora, like the ones coming from America, are the ones who did the first open heart surgery in Tukurambasa Hospital. And then that was followed by the German group with Dr. Kefelegn Dejene. And currently, I know a large number of groups were coming from Egypt, the United Kingdom, nearly all over the world to the Cardiac Center Ethiopia. Although I don't know what's happening now because in the presence of Shibikom, maybe and Kefelegn and Mohammed, just soliciting consumables might be just enough. That's the understanding I have because they are doing those procedures elegantly. But in Tukurambasa, a group from Norway, led by Dr. Nuguse Bogale, and Swedish group was also coming with Dr. Leo. So our colleagues in diaspora are trying to help our circumstances as well. That has to be noted. The Addis Cardiac group, led by Dr. Fukro, must be, I think, appreciated for introducing PCI in this country. And then Cardiac Center Ethiopia was having several missions, subsequently dedicated, outstanding surgeons and cardiologists were trained in India and have taken over the entire aspect of the hospital. The fellowship program in Tukurambasa and the Millennium Medical School was also very contributory to the current status of over maybe 70 cardiologists, maybe more than 5-6 cardiac surgeons, and a few cardiac anesthesiologists. The creation of our society and its especially academic move is very impressive. I think I would like that the society to make an agenda, the important point I was emphasizing earlier. Addis Cardiac has introduced, like, the duties were covered by senior good residents, and then cardiologist follow-up started at that place. And young internists were also inspired to become interventional cardiologists. So, and strict application of consultation systems, I think those are the prides of Addis Cardiac Hospital. Cardiac Center Ethiopia, as I said, missions, the training of the several professionals. I was saying the fellowship in the society are really, they have helped our move. So what are the suggested solutions currently? I think I'll be winding up my talk with this slide. Attention and planning is needed from the concerned bodies of the government. The ones I have mentioned, like Ministry of Health, Ministry of Finance, Ministry of Revenue, FMHK, the tax authority, they have to be approached. They have to know what prevails in our hands. Otherwise, everything will freeze and cease. Creation of centers of excellence. The Ministry of Health should support Tukur Ambassa and Millennium Medical School, in my understanding. Planning of sustainable provision of insurance system is critically important for us. And right now, we need to have some allocated foreign money for the sector, the procedures we're dealing with day by day. We should also increase the know-how and motivation of the pharmaceutical importers. The pharmaceutical industry has to understand the particular circumstances, and academic institutions, private centers, and the society should move to strengthen their efforts that they are making today. And health education is critically important because, as I indicated in our study with Dr. Lamlam, we do have probably the poorest understanding about chest pain and its consequences in our country. Thank you very much.
Thank you, Dr. Bekele, for taking us a journey almost from 20 years back till now. That's very interesting. 17. Okay. That's interesting. Where was there? What they are doing now? And as a country, we faced what they has faced till now most of the time, especially consumables, very big neck bottle. The biggest problem, as Dr. Bekele said, is awareness for the people who can afford, who can come to the PCI center, but usually they come late. So this is, so society will take this opportunity, and we are doing also with some mass medias by propagation and the promotion of awareness. And the issue of consumables, I think that will need a very big discussion. So I will give for our audience, both in person and virtual, if they have any question, discussion, please forward for that.
Thank you, Dr. Bekele. It's a pleasure, actually, to listen to your and attend your presentations, actually. It's quite elaborative and it's a very nice one. My question is just, what is the current status? Now, currently, just now, I have developed acute coronary syndrome.
Current status.
Now, just now, I have developed now. I've got chest pain. Is there a center which is really ready to help me right away?
Oh.
Now versus just after midnight. Let's see, just practical thing.
I would like this question to be answered by Dr. Chala. I shouldn't be involved to answer.
Dr. Chala is interventional cardiologist and the chairman of the society.
So thank you for raising this question. It would be a response and awareness creation, not only for Dr. Shibikom and this audience. And I want the rest of the medical community to know this as well. So in Gesund Cardiac Center, we have a team of professionals who is ready to be activated. If an individual with acute MI happens to arrive to the center within time window where the benefit of PCI is the most. So let's say, as you said, if you have chest pain right now, so the ambulance would be collecting all the health professionals around the institution, and the Cath Lab would be activated and the procedure will be done right away. So there is no delay at all, except where the situation is from transportation issues, from the patient awareness and other factors. Otherwise, primary PCI is available 24 hours, 7 days a week.
The problem is, do you have money? So it is very good thing that the Cath Lab is open anytime.
I think when I was thinking, what is the average number of genuine, real primary PCIs we do over a month, or a year, or a week? You know, we are currently doing, like in Addis Cardiac, we're doing around 12 per month. That was the average I had. Now it has come to at least a minimum of 1 in a week. That means the number has exceeded real primary PCI within 12 hours boundary. So it has exceeded 50 per year. So that is, you know, even in terms of caseload, it's very, very good now, you can say. Because the limit in terms of caseload when it comes to primary PCI is around 36 per annum in the West. That's what they write. So there is no question about it. The problem is our center is a little far from the center, and traffic jam is a little stiff towards our center. Otherwise, at any time of the day, as Dr. Chala said, we're more than happy to enjoy it.
Okay, I think this is a very big plus for ACS having timely intervention. Thank you, Gesund. Yes, Doctor.
Thank you. Mine is a witness, just to give a witness. One Sunday morning, me and my colleague, a senior colleague, gynecologist, having a play in a tennis ground. After 30 minutes of tennis ground play, he fainted. And really had severe chest pain. It was early Sunday morning. Most of the Ethiopian people Sunday morning will be in a church. So I called my good friend Bekele, who assisted me because I have to drive him. There was no ambulance from the tennis court to the car. And we reached within 35, 40 minutes. Almost he collapsed in my car. So I think he was assisted and he was doing good. So I think it's the willingness and the awareness. I'm a primary care physician in Sunday morning, not in the emergency room. It is in the tennis court. So anytime I think it's possible, the man has to drive to the nearest center. I think Bekele can correct me.
That is true. Unfortunately, both RC and the CERC were concluding. It was even difficult to know the culprit because the ECG change was limited to the inferior leads and some of the lateral leads. So we did both of them. And he's now switching between America and Washington and Addis.
Interesting. Thank you. Any more?
Thank you. We have 4 questions so far from our virtual attendees. The first question reads, what is the estimated price of PCI and coronary artery bypass graft?
I think this type of question, this is an academic session. We're not, we're only supposed to state science. And we have achieved, in terms of procedures, our capabilities, the number of professionals we have. I can't go beyond this. And I'm not, even if that is to be answered, I'm not the individual who should respond to bypass surgery as a cardiologist.
Thank you. The second question reads, are there any simplified, low-cost versions of PCI equipment that are suitable for resource-limited settings? Resource-limited settings.
Well, we have tried this at the Black Line Hospital. Unfortunately, first of all, the first Cath Lab installed in the Black Line was supposed to be for St. Paul's, But because there was no individual who could do the procedures, that was switched to the block line, and then we created those individuals who are entitled for free. We're having it for free, but even the paying individuals we're paying very low cost, like it was cost very limited amount of money was there. So the best thing is to continue, like if the initiatives are spread within the society and beyond, I think that is quite attainable. Otherwise, we have already tested it in the Black Lion Hospital. And the same thing, in fact, PCI is still being done for free at the cardiac center whenever the facility, when I say the facility, the consumables are available. So there are possibilities, but very limited because the cardiac center has a limited support, and the Black Lion Hospital, by the way, we exhausted, it was a turnkey project, supposed to be for 5 years. We exhausted everything in 6 months. We're there 7 o'clock, like the way we do engagement.
The last question reads, is there any epidemiological paradigm shift in the occurrence of acute coronary syndrome in Ethiopia? For instance, a tendency to see it in younger individuals.
In the tendency to see it?
In younger individuals.
Whether that is a paradigm shift or whether we are in already, I can't tell. Because since my serious practice started, I frequently see younger individuals. Like in Addis Cardiac, I could see anterior STEMI in a 22-year-old university student. That was some 9-10 years ago. And the same thing is happening now in this. So, as well as Black Line. So, the average age of coronary disease we have come through successively in our studies, it's ranging between 56, 57, 58 year of age. I mean, year-old individuals develop on average both chronic and acute coronary syndrome. I don't have a separate figure for STEMI. That must be very low, maybe mid-40s or even below. All what I can say is our population encounters the disease, especially ST elevation AMI, at a very younger age. And probably this is very parallel to what's happening in India, because the Indian population, I know, like Southern Asia, tolerates poorly abdominal fat. That's very well known, studied. And probably the same thing is happening in Ethiopia as well, because the average age of coronary disease in the West is beyond 60. Even there are some figures which say 76. So ours is very much lower than that. Whether that is a paradigm shift or existing fact, one cannot state.
Okay, I think we are through. Let's give Dr. Bekele, very nice. Thank you, Dr. Bekele, for coming from your very busy schedule, I know. So the second session will be moderated by Dr. Shibikom. Dr. Shibikom is a cardiac surgeon, both adult and pediatric. Currently is doing in cardiac center in the private. So he's my colleague, starting from our medical school till now. And so I'll call Dr. Shibikom to introduce the second presenter.
All right, thank you. I think good evening, is it? Quite late afternoon. So it is an honor to introduce the Dr. Subhash Kumar, but yesterday I asked him whether I should call him Dr. Kumar. He said, okay, so it's okay. So Dr. Kumar has been doing cardiac surgery since 1986. That's so, yeah. So he has been doing surgery in different specialty hospitals. And since 2016, he's working at Max Hospital. But starting from 2018, he's working at Max Super Specialty Hospital, which is at Saket. And he has been working in different centers. He has received different awards and accomplishments as well. And he's a lifetime member of Indian Association of Cardiovascular and Thoracic Surgeons and Cardiology Society of India. And he has got he has received different recognitions, specifically with beating heart cardiac surgery. So there's a better person in the room who can tell us about minimally invasive cardiac surgery, because that is one area of his specialty. So it looks like the current trend of cardiac surgery. So thank you for coming all the way to Ethiopia and giving us your experience and sharing us. Thank you.
Thank you so much. It's a nice, lively afternoon, and I find myself very fortunate to have come to this place. Good weather, good air. So I'm going to speak something about current trends in cardiac surgery, what we are doing and what we have improved over the past nearly 20 years or more. See, cardiac surgery is changing every day. We have come a long way from ligating PDAs and creating shunts. It has become much safer. Apart from that, a very important shift, what has happened is catheter-based technology, which the cardiologists do, is further going to make it as a daycare surgery. So what new do we have? I've classified it into coronary artery disease, valves, congenital diseases. I'll leave the congenital diseases to my colleague who will be speaking after this. Then heart failure therapy, ECMO, left ventricular assist devices, heart transplant, and then catheter-based technology, which will be spoken by Dr. Rajiv. In the coronary artery disease, with the boom in catheter-based interventions, most of the coronary artery disease is being slowly taken over by the cardiologist. There was a time when we started, all the cases of coronary artery blockage was supposed to undergo a bypass, whether it is a single vessel disease or a double vessel disease. It is no longer there. Even triple vessel disease, and most of them are being done by the cardiologist. So what we had to do? What we had to do was improve ourselves. So what we improved, we went to total arterial revascularization. We stopped using the heart-lung machine, and it became an off-pump surgery, which had better and faster recovery. Then came the minimally invasive procedures by a left thoracotomy. And also, instead of having a long scar on the leg to harvest the saphenous vein, we started doing endoscopic vein harvestings. So where we are, most of the things which are in the color blue is still with the surgeons, whereas most of the single vessels, long lesions, multiple vessel disease has been taken over by the cardiologists, and they are doing PCIs for that. We have to do more complicated cases, more of LV dysfunctions in cardiogenic shock. Maybe if it's a triple vessel disease, the surgical results are better. If the patient has got diffuse vessel disease, the patient is a diabetic, or he's got renal failure, he's on dialysis, surgery is better. Critical left main, I still feel that it is in the purview of the surgeons. And then if you have had a stent and it has got blocked, 1 or 2 stents, it's better to undergo a coronary artery bypass rather than having another stent. So this is all what we have improved. Total arterial revascularization is definitely possible. We use both the intermammary arteries. We use the radial artery. We do a composite grafts. And this also avoids the side biting clamp on the aorta, so the chances of having a post-operative neurological problem does not happen. Internal mammary is a very good conduit. It's nearly immune to atherosclerosis. If you put an internal mammary, you must be sure that it will last more than 25 years, 30 years, and so on. I have got patients who are operated at least 20, 25 years back, and their internal mammary arteries are still going strong. Now coming to valves. We have got improvement in the quality of the valves. This is a historical importance. Dr. Albert Starr first used this poppet type of Starr Edward valve, and more than 230,000 implants were used worldwide. But unfortunately, this valve is no longer in use. The last Starr Edward valve I used was way back in the year 2000. That's nearly 24, 25 years back. Mechanical valve designs have improved over years, leading to low thrombogenicity and better hemodynamic performance. So most commonly what we are using nowadays is open pivot valves. And this open pivot valve has got low thrombogenicity. Single leaflet valve is still in India. We have got a Sri Chitra TTK valve, which is manufactured in India itself, and that is being used still in our country. Now, if you see what is the problem, if the patient does not have a good anticoagulation, the valve will develop thrombus, or if the patient stops taking these anticoagulants, then he will have a stuck valve. The ideal valve is not yet made. The ideal valve is one which will last the lifetime. It must be constructed of biomaterials that are non-antigenic, non-toxic, non-carcinogenic, and it also should have a low incidence of thromboembolism. So the biological valve comes into being. The problem with biological valves are, though thrombogenicity is not there, but the only thing that it degenerates very fast. The earlier valves used to degenerate within a span of 7 to 10 years, and especially in younger patients, that was a disaster because they have to undergo another repeat surgery. And this was not always feasible, both financial constraints and the risk involved. However, if the patient was above 65 years of age, then these valves were very good. This is one of the very good bioprosthetic valves, and this is supposed to last more than 20 years. However, just because it is in the market and we do not know how much this is going to last. Another very important and interesting thing which came into cardiac surgery was doing a minimally invasive cardiac surgery. So with using a right thoracotomy, we can put the patient on a bypass using the femoral route, a femoral bypass, and make a small incision and do a mitral valve replacement or an aortic valve replacement, a closure of ASDs, LMXomas, that all can come under the minimally invasive way. The important thing is that we used to get used to it. We have got long instruments and standard instruments for that. And you can see this is the scar what we give, and especially in the ladies, the cosmetically, this is a very good incision. In the aortic valve, we can do either a right thoracotomy or a small hemisternotomy, and we do an upper hemisternotomy, so the scar is very less. Then comes the sutureless valves. We got Edward sutureless valve, where with the help of only 1 or 2 sutures, with the help of a cage, what is used in the TAVI and all, it can be easily placed at the desired junction. Especially when you are doing a right thoracotomy, a small incision, the sutureless valves cuts the time and is very good to put it there. So these are some of the sutureless valves which are available in the market. Now coming to congenital disease, this will be dealt with in the later part. Now, extracorporeal membrane oxygenation. This has become life-saving in certain cases like ARDS, H1N1, and other reversible lung ailments. The importance is the patient should have a severe LV dysfunction. Sometimes in post-CABG or a valve replacement, if the ejection fraction is low, we can put the patient on extracorporeal membrane oxygenator and wait for the heart to recover. The important thing is that this can be kept on for 2 weeks, 3 weeks, 4 weeks, till the heart recovers. Here, a word of caution that one should use these cases on put the patient ECMO when we are certain that the pathology behind it is recoverable. That means it is going to improve after some time. This also is being used in certain cases where the patient is waiting for a transplant with the end-stage cardiac failure, and we put the patient on ECMO and wait for the patient to get a new heart. Sometimes in viral myocarditis, this is a very good thing. We can put a patient on ECMO. It will usually subside within 2 to 3 weeks, and the patient will be all right. The basis behind is we drain the venous blood and we add an oxygenator to it and return the blood to circulation. Now, this can be either a veno-venous ECMO or a veno-arterial ECMO. This is one of the patients where we had put an ECMO, and this is exactly the type of thing. The whole contraption can be attached to the patient's bed, and the patient can be managed very well in the ICU. Now, the other LV assist devices are IABP, CentriMac, Thoracic, then HeartMates 2 and 3. Jarvik is a new heart, you can say, artificial heart, what is there. So these LV support system can be either a bridge to decision or a bridge till you get a new heart. So nowadays, once we saw that these left ventricular assist devices could be kept for quite some time, so we started putting it as in the end stage disease as a thing which is going to last and work like an artificial heart. This is how it is usually put. There is an outflow graft, and if you see from the LV, there is an apex, there is a pump which is going on. In between, there is a rotational pump. It augments the pressure and it is put into the ascending aorta. It looks like something like this. During surgery, this contraption is sewn into the heart and then the contraption is attached, whereas the contraption is attached, there is a pipe which is, the blood comes through this pipe, goes to the pump, and then it is pushed back. And then there is a battery line and a battery backup. What you have that is in the abdomen, or you can carry, the battery can be carried like a bag or like a purse, especially ladies. I have seen one lady carrying it like a purse, and you could not even make out that she has undergone this operation. This is exactly how it works. And if you do a X-ray, it will be something looking like this. This is one of the patients who was on this LVAD, and he was there for about nearly 4 years on ECMO, and later he underwent a cardiac transplant. Heart transplant is a reality now. The numbers have increased because the public awareness of donating their organs has become more. And also, if you get a heart somewhere in the periphery, it can be always transported with the help of the flights, and the police does create a corridor so that from the airport to our hospital, it takes just 10 minutes. The driver goes at the utmost speed and there is no traffic on the roads. That all traffic is held up. In heart failure, there have been a lot of improvements, and once it becomes end stage, either the patient undergoes a transplant or he opts for a LV assist device. This is one of our heart transplant patients, a pretty young person, and this is about a week after surgery. He's sitting up and he was discharged, and after 2 years, he is still going strong. Now, robot has slowly come into cardiac surgery that enhances the surgeon's ability to carry out minimally invasive procedures, and current operations which we can use using a robot is atrial septal defect, a mammary, internal mammary takedown is used this way. Then we can use the bipolar pacing lead placements. Mitral valve replacement and repairs are being tried, but that takes a lot of time, and so it is not usually that very commonly used, and not many people are trained for it. Transcatheter aortic valve replacement, I leave it to Dr. Rajiv. That's all. So these are the improvements what I feel in cardiac surgery has come.
Thank you, sir, for your nice presentation. Can you take a seat there or, yeah, thank you so much. All right, so if you go through the history of cardiac surgery, how it has evolved since 1950s, it is actually quite fascinating. And where we are now, I think it has been reflected by different cardiac surgeons who are working in Ethiopia at different society meetings. So it is an honor for sir to come here and to give us a thought on the course of cardiac surgery, how it looks like in the years. So if there is any questions or comments from the floor, they are most welcome. Any questions?
Thank you, sir, for highlighting us the spectrum of cardiac surgery. My question is especially in minimal invasive cardiac surgery. What do you think for developing countries like Ethiopia? Do you think shall we jump from the bigger incision to minimal invasive surgery, especially for cost-wise in Ethiopia?
Cost-wise, minimal invasive surgery does not cost much because the surgery remains the same, the equipment remains the same. You go on a heart-lung bypass using an aortic cannula and a venous cannula. Here the aortic cannula is put via femoral route and the aortic cannula is put on the femoral vein. The only difference is that you should have maybe 4 or 5 long instruments which is used in this. Sometimes it becomes necessary. Otherwise, you can use a long forceps and a long scissors like a routine surgery. So you will not say that you cannot do it here. The cost is heavy. It's not. Only thing you have to get trained for it.
So what about accesses? Surgery is going to trans accesses. How do you see the complication of these accesses on the femur?
Usually, it's not anything different because you have to get used to how you cannot go on digging and trying to do a femoral route. If you dig too much, you cut too many lymphatics, then you'll have something, it will keep on oozing. So that is the precaution. You just go straight for the femoral artery and the femoral vein. Do not dissect too much. Do not cut out too much tissues. That's the basic thing. As far as the thoracic incision is concerned, again, the same thing. If you do not dissect too much, you are okay. Initially, when you are starting, you should start with thin, lean, thin patients, and later on go for more fatty and obese patients. And as compared to sternotomy, basically the thing is that it's a cosmetic thing that everybody should understand. It's nothing new. You are doing the same thing. Even if you are doing a CABG from the left thoracotomy, what you are doing is a graft in the same way. Only thing you are making the incision instead of sternotomy, you are making a thoracotomy incision. And slowly you are going to decrease the size of the instruments, size of the incision. And especially in ladies, if you put a submammary incision, the scar doesn't show, and they are very happy with it, especially younger females.
Thank you. Any questions?
Thank you. I have just maybe a simple question. Is age a factor for heart transplant? And my second question is, how is the survival rate post-transplant?
Post-transplant. Post-transplant, if they take medicines regularly, usually up to 4 or 5 years, there is no problem. As far as age is concerned, we'll prefer to a younger patient for a transplant rather than anybody above the age of, say, 70 or so. It's always preferable to have a younger patient.
Any questions? I think I saw hands being raised around here. Anybody with questions?
Okay, thank you. My question is, can we use this minimal invasive surgery for all types of cardiac surgeries, or is it for specific or selected cases, particularly in small kids? Is it possible to use?
The problem with small kids to do minimally invasive surgery is the femoral arteries are very small. So to cannulate a femoral artery of that small and going on a bypass is really sometimes not feasible. So I would not say that you should go for a minimally invasive surgery for very small children unless you are really very experienced with it and you have the very small cannulas and all. As far as in the adults are concerned, I am not doing any ASD by a sternotomy. All of my ASDs are done by right thoracotomy. Nearly 50 to 60% of my mitral valves are being done from right thoracotomy. Only exception, which I still am not very confident is doing, is really bad hearts, huge hearts. Means I can do it, but then the patient also has to come off and other things. And sometimes that you can land up yourself into problem. So these are the places where, as far as aortic valve is concerned, most of the aortic valves can be done using a hemisternotomy or a right thoracotomy.
Thank you. Any other question? Okay, is there any question from the online audiences? Okay, so we have got questions from online attendees. So the first question is, which revascular strategy, surgery versus PCI, do you prefer in terms of long-term mortality and recurrence in older patients? I think older individuals are asking questions more.
Well, this is a very controversial thing with PCI versus CABG, which should be done and which should not be done, because even with PCI in a single vessel disease, the patient is expected to live its normal life. And with a surgery, if it's a single vessel disease, you do a Lima to LAD, it is going to last the normal life. The controversy comes in left main disease and triple vessel disease. Here, depending on the type of vessels, what the patient has. My personal thing is that all left mains should undergo a CABG operation. I don't know what Rajiv will have to say about it, but this is my personal thing. And most of the literature supports that. Similarly, most of the triple vessel disease also come into the surgeon's purview. Though if you have very small focal lesions, even a triple vessel disease, PCI will give equally good results and CABG will give the same good results.
So in Sinha, usually we approach it with a syntax score, isn't it?
Yeah.
We approach it with the syntax score that will tell us what the problem is in the gray zone. That is the area of controversy, whether to go for surgery. It also depends on the expertise we have, the type of, patient, what we have. So it needs further team discussion really to come up with a decision. So another question from online audience. Namaste, Dr. Kumar. That's how it has been written here. So thank you for the update. So what is your experience with regard to the structural deterioration of prosthetic valves? Prosthetic valves.
What is the structural?
Structural deterioration in bioprosthetic valves. What is your
structural deterioration?
Yeah, with regard to prosthetic valves.
Bioprosthetic,
yes.
Bioprosthetic valves. Normally, the older generation of the bioprosthetic valves normally would degenerate within 8 to 10 years. And especially if it was used in younger patients that is less than 60 years of age. The recent valves, I've had good results, and maybe I've had some patients are there for the past nearly 20 years, 22 years also. The Perimount valves, which I have been started using in the year 1997 onwards, I have got patients who are still going strong with no valvular degeneration even now. That is nearly 20 to 22 years. And I will not say that I've been following all my patients, but yes, majority of them are under my follow.
Thank you. Those are all the questions from the audience as well. Thank you so much, sir, for your nice
Thank you so
presentation as well. So the whole thing on capacitive valves is the way they are being manufactured, isn't it? How they are being, the decalcification, calcification, the preservation, and everything. Yeah, that has improved. And thank you so much. So next is about pediatric cardiology. So we have to make the presentation somehow comprehensive. So I will call upon Dr. Ali to introduce the next presenter. Dr. Ali is a good friend of mine and a colleague in the brother. It is an honor to call you here as well as introduce our presenter. So Dr. Ali is the only pediatric interventional cardiologist in Ethiopia. So it's an honor for you to be introduced by Dr. Ali as well, please. Thank you.
Okay, thank you, Shi. Good evening, everybody. I'm really happy for me to be here with you again for obvious reasons that you know. So having said this, the next presenter will be Dr. Gaurav Kumar, who is a senior and consultant pediatric cardiologist from Max Specialty Super Specialty Hospital. Dr. Kumar is having an immense experience on pediatric cardiology and having multiple publications and experiences with multiple awards from the country he is originated. And the point of discussion will be when and what to intervene, particularly in pediatric heart disease. So I will leave the floor for Dr. Kumar. Thank you.
Good evening, everyone. At the outset, I'd like to thank the Cardiac Society for inviting us over here to share our knowledge. And after discussions on the adult cardiology and the adult surgical part, we'll move to the pediatric cardiology. I'd like this to be an interactive interaction, okay? Because I'll be discussing multiple case scenarios and I want your involvement as well. I like Dr. Ali to involve the audience because he'll be knowing much of the audience from here. At the outset, there's no conflict of interest. All pictures being used in the presentation have been used with permission. So what's the burden of CHD? The graph is showing the prevalence of the congenital heart disease during the era of 1990s. You can see the high prevalence in the African and all in the Southeast Asian region. The prevalence rates have not much changed in the 2000, this is as compared in the 2017. And this being the mortality ratios with the average annual percentage change, which have also not much changed. So the African subcontinent and the Southeast Asia still continue to have predominant with high prevalence rates. So, congenital heart disease are the most common birth defects. Nearly 1/3 of the all congenital defects, with a worldwide incidence of around 17.9 per thousand worldwide, as per 2022 data, where approximately 10 in India, approximately about 10% of the infant mortality can be attributed to congenital heart disease, with the birth prevalence of around 8 to 12 per thousand of births. Every year, around more than 2 lakhs children are born with a CHD in every year, and about 1/5 of these will be requiring or have critical heart disease and requiring early intervention in early infancy. So it remains a tremendous challenge for all the families, society, and the healthcare system in all of the developing world, which we are part of. The major questions remain if a child presents with a congenital heart disease, what to do and when to do. I'll be covering these two aspects mainly in my talk so that the timely referral and timely intervention can save these lives. Advances in pediatric cardiology and cardiac surgery have made it possible to repair or palliate most of the CHDs, including the complex ones. If access to screening, early diagnosis and treatment is available, over 90% of these children can survive to adult life with good long-term outcomes. Broadly, though the demarcation is less clear, can be classified into cyanotic CHDs with left to right shunts, obstructive lesions, cyanotic CHDs with decreased pulmonary blood flow, including the pathophysiology lesions, VSDPS, Eisenmenger's physiology, and the increased pulmonary blood flow lesions, the admixture lesions. The miscellaneous group being abstinence anomalies, systemic venous anomalies, and AV fistula. Though the demarcation is still not very clear because some of the lesions will be having overlapping features with comorbidities like anemia, syndromic association also affecting presentation. This is a child, infant with failure to thrive, no history of apparent cyanosis, as you can see in the picture. Was severely anemic with a hemoglobin of 5.5 and only with a unsaturating 48%. Echo done showed a cyanotic CHD, transposition of great arteries. So my first case is an 8-day-old baby on oral feeds, a routine murmur detected on a routine evaluation, no features of CHF, cyanosis, peripheral pulses, femorals are well palpable, was sent for echo. A non-restrictive VSD, VSD shunting left to right was found with a PAH. What should be the plan? Should we wait and regular follow-up, start decongestive treatment, emergency referral for surgery? Any response? Dr. Ali, will you help us out? What should be the plan? Any of your friends can ask. Any of your friends want to participate in the, I'll be doing a case-based. This is a 8-day-old child with a murmur routinely detected evaluation. Echo showed a large VSD with a large left right shunt with a PH.
So what do you want me to do?
Yeah, so I've just put up the 3 options to plan.
Oh,
So that the audience can.
is or maybe on oral feeds permit detector or evaluations. So anybody on the plan of management?
We can give a mic to the audience. Anyone wants to.
Anybody? 8-day-old baby on oral feeds, murmur detected on rhythm evaluation, not in heart failure, no cyanosis, femoral is normal, or shows same for echo.
Which option?
There is membrane space left right shunt, H. So what is the plan of management?
Yeah, absolutely. As sir has rightly pointed out that this being only 8-day-old baby, we should wait, allow the child to gain weight, and for a large VSDs, elective surgery at around 3 to 6 months. Another case, 3-month-old baby presenting with tachypnea, tachycardia, failure to gain weight, admitted with an episode of pneumonia. You can see severe retractions, subcostal retractions, CHF in PH, normal femoral. Echo showed a non-restrictive VSD shunting left to right, hyperkinetic PH. Plan. Should we start decongestive, antibiotic, and suspect chest infection? Plan for early surgery, direct referral for surgery, and VSD or VSD surgery cannot be done in such a small baby.
So what will be the management, the plan of management, this particular patient?
Anyone?
Admitted for pneumonia. Failure.
Yeah,
Sorry?
so some of us have already pointed the first option. We should start on decongestives, optimize the baby for before the surgery, treat any infection, and then plan for early surgery. All these babies with a large and restrictive VSDs ideally should be operated between 3 to 6 months of age. Next case, 6-year-old asymptomatic child, pansystolic murmur in left sternal border, no mid-diastolic murmurs, no S3 rumble. Plan. Early echo and due to recurrent cough and cold, early surgery, even if the VSD is small, or elective echos with the option being given to the parents that the child may require VSD closure in future. So the second option, right? This being a restrictive VSD causing a pansystolic murmur, no volume features of volume overload causing LALV dilatation. Surgery is not indicated at this juncture. Child should ideally be followed up every 6 months to a year. And when the child showed any features of LV dilatation, may require VSD closure, which may be either a surgery or a device. So what's the natural history of a VSD? Around 20% show decrease in size and closure, especially the muscular ones. Around 6% of the patients can have aortic regurgitation because of the RCC collapse. Infective endocarditis can be seen up to 3 to 4% and can develop infundibular PS because of the high velocity jet in around 7% of the cases. Around between 5 to 20% of these children can unfortunately progress to Eisenmenger syndrome. Our target should be all large VSD should be sent for surgery at least before 2 years of age, ideally between 3 to 6 months of age, so that we do not need to treat these Eisenmengers because the surgery has excellent results. So in the finalization and large indications of VSD closure, large VSD, to start on a high caloric feed, breastfeeding should be encouraged. Start on cardiac decongestive medications, including Lasix and Eldecton. Elective closure between 3 to 6 months if stable on medication, if not early surgery. Moderate side VSD, elective closure 6 months to 1 year if child stable. Restricted VSD is not showing any features of LV dilatation with normal PA pressures can be medically followed up with spontaneous bacterial endocarditis prophylaxis. Modality still remains predominantly for surgical for larger VSD. Selective cases can undergo device closure and have excellent results with less than 1% of mortality. This being showing a perivoluminous VSD being closed with a device, nicely no shunt after the device closures. Next case, 3-month-old stable child, ejection systolic murmur on routine evaluation for vaccination. Echo done showed a fossa vallis ASD of 8 mm. Mildly dilated RARV, normal P pressures. Plan. Start on digoxin, Lasix, and early surgery. No cardiac medication at present, and follow-up may require closure later.
Anybody? The second option.
Yeah, as Dr. Ali has rightly pointed, is a stable child with a ASD of around 8 mm only. We can only follow up and may require closure later. Next, 2-year-old child with no symptoms, evaluated, noted to have a murmur on routine evaluation, no features of CHF, echo showing 16 mm fossa vallis ASD, dilated RARV. What should we do? No need of intervention. Should we do elective closure, decongestive treatment, early surgical closure?
Anybody? For this particular patient, 2 years, 16 mm, fossa vallis ASD.
This can be electively closed. Yeah. So most of the ASDs, if causing RARV volume overload, should be electively closed between 2 to 4 years of age. The mode of modality, the surgical device depends on the adequacy of the rims. Next case, 6-month-old child, failure to thrive, tachypnea, tachycardia, cardiomegaly, showing large ASDs, dilated RARV, PH. What should be the plan? Should you get repeat echo by the pediatric cardiologist? Or should you agree with the echo findings? Should we start on decongestive treatment, early ASD closure, wait for closure, or nothing can be done?
Anybody? 6 months old, large ASD, dilated RARV, PH.
So my plan will be in this case will be to get a repeat echo to look for any associated relation if anything has been missed. But still, if you are unable to find out a small fraction, around 10% of the patients of the ASD can have infantile presentation with a failure to thrive. Those may be requiring a decongestive treatment under closure. So with probability of decrease in size, most of the ASDs less than 5 to 6 mm can have a high chance of spontaneous closure. More than 8 mm usually have around 10% chance of spontaneous closure. Ideal age of closure remains 2 to 4 years. If presenting late, whenever detected, should be closed, though amounting to acceptable PA pressures. Closure at less than 24 years, survival complementary controls. More than 25 years, late survival, this, but still closure helps. Modality, mainly device, sinus venosus, primum, large fossa vallis without adequate rims need to be sent for surgery. We showed excellent results with less than 1% mortality. This was an adult gentleman of around 65 years of age, came to us for an opinion for a clearance for a laparoscopic cholecystectomy. On evaluation was noted to have a large ASD, underwent device closures, then remained healthy. This is showing the LEO view, showing atrial device, and the transesophageal echo showing device insert C2 with holding onto all rims. Next, 6 days old, 32 weeks preterm baby, tachycardic, tachypneic, ESM, echo showing 2.4 mm PDA. What should you do? Start on decongestives, start medical therapy, no response, surgical ligation. So this should, if the child beyond a week remains in CHF and you're suspecting it to be due to a PDA, start on decongestive, start on medical measures first. Most of these children will be able to close the PDAs by medical measures. We are using paracetamol in our country with showing excellent results. A small fraction not responding to medical therapy will be requiring surgical ligation, and in some selective cases, device closures as well. Another 1-year-old child, stable, evaluated for upper respiratory tract infection, noted to have a continuous murmur. Echo showed a 3 mm PDA with normal PA pressures. The plan should be a percutaneous closure of PDA if no other indication for surgery. So recommendations are a preterm PDA with a hemodynamically significant. Try pharmacological closure first by either of the agents, paracetamol, indomethacin, or ibuprofen. No proven role of Lasix. If not stable, early surgical ligation. Large PDA with CHF denial early closure, and any audible PDA with contents but to be closed electively. Modality in preterm neonates with CHF largely surgical, device closure in selective cases. Later device remains the mainstay. Excellent result showing less than 1% mortality. This was a child with us 2 months old, 2.5 kg with a severe failure to thrive, had a birth weight of 3 kg, 3 months post PDA ligation, child thriving well, gaining weight. Is showing a large PDA. This being the RAOV showing the presence of a large VA. Closed by a well-10 device. This was an older child, I think. The post-procedure echo showing lamina flows in both the branch P with the device in situ. And no features of coarctation. AVSD. The complete AVSD is the commonest CHD in Down syndrome. CHF and PH develops early in these cases. Should be like electively operated between 3 to 6 months of age. Earlier surgery in babies with Down syndrome. The rastly type A remains an independent risk factor for early PVOD in these cases. AP window, a rare congenital heart disease, early development of PVOD is the rule. Patient will present with the CHF, hyperkinetic pH, and significant murmur. Uncontrolled heart failure, surgical repair should be done as soon as possible. Controlled heart failure, elective surgical repair by 3 to 6 months of age. Usually being closed, usually surgically. Restricted AP window, device closure can be done and should be attempted. So what's the natural history? All large life threatened will be causing increased pulmonary blood flow. And we have to get these patients intervened at this juncture. If they progress to the irreversible pulmonary vascular injury with increased PVRI, the shunt will become directional and they'll be Eisenmenger for their lives. Coming to the cyanotic subsets, 3 days old neonate, cyanosis, SpO2 of 60%, good peripheral pulses, chest X-ray, no lung pathology. Plan. Should be intubate, treat for chest infection, start PG1 infusion, ask for echo, wait for echo before starting PG1, or nothing can be done. Anyone?
3 days old, cyanos 60% saturation.
So this child very highly likely to have a ventricular disease with a probably a drug-dependent lesion. So we should start on PG1 infusion and then ask for echo. On echo, should the complete TJ with intact ventricular septum, how do you manage? So start maintain fluid electrolyte temperature, start PG1 and transfer to pediatric cardiac center. May require a BAS or an early arterial switch. This was, I think this video is not working. BAS being done showing unrestricted ASD post-BAS. So what are the guidelines for TGA operability? TGA with intact interventricular septum should be ideally operated between 7 days to 3 weeks. Earlier, if baby is unstable or associated with PHN. Exact timing usually is institutional preference, but should be done before 4 weeks before the LV regresses. TJ with large VSD or PDAs should be closed by 6 weeks of age. These children are very high prone for developing early pulmonary vascular disease because of the hypoxia and presence of the TGA per se. TJ IVS with the late presentation can undergo a rapid 2-stage switch where a PA band being done for the LV training and then succumbing to arterial switch 1 or 2 weeks later. Or if the LV remains regressed and the experience is not there, can undergo a sending or a muster. TJ VSD PA is infantile presentation, BT shunt to augment the pulmonary blood flow, and rastally later on with the conduit VSD. Another subset, if an echo critical valvular PS with intact ventricular septum. Maintain fluid electrolyte temperature, start PG1, transfer to a pediatric cardiac center. BPV shows excellent results in these cases. This was a child who presented with a valvular pulmonary atresia. We planned for a valve perforation, balloon dilatation. This was being crossed by a CTO wire. This was the post-procedure results with very good anti-good pulmonary blood flow being established. 2-day-old with severe respiratory distress, cyanosis, no cardiomegaly, white lung. Only 2 DDs comes to our mind. Most common being respiratory distress syndrome treated by surfactant or obstructive TAPVC. Echo showed obstructive TAPVC, emergency surgery will be required in these subsets. So unobstructed TAPVC is a large ASD with laminar flows in the pulmonary venous conferences, usually have good mixing. They usually present only with a CHF with saturations of around 89 to 90. Obstructive TAPVC will be the sicker lot with marked cyanosis with respiratory distress in neonatal period. This was a child who got operated with obstructive TAPVC. This is post-operative day 7, just before discharge, doing very well. So surgical intervention is necessary. Obstructive TAPVC is a surgical emergency. non-obstructed surgery at the time of the diagnosis. A 6-month-old child with cyanotic spal, treatment plan. So we should treat the precipitating factor, knee chest position, hydration, beta blockers, morphine to calm the child, and will be requiring early surgery. And if not managed, can intubate and ventilate and then plan for early surgery. 3-year-old child with mild central cyanosis, no CHF, an echo top with adequate anatomy. What should be the plan? So there is already 3-year-old with adequate anatomy should be referred for surgery. So what are the indications for timing for surgery in TOF? Neonate with severe cyanosis with a pulmonary atresia or a critical PS, BT shunt or ductal stenting to augment the pulmonary blood flow, later total correction. A stable TOF ideally should be operated between 6 months to a year. TOF with recurrent cyanotic spill, start on beta blockers, if less than 3 months BT shunt, later total correction of PSI is adequate. Results are excellent. Long-term concerns remain of the pulmonary regurgitation because of the transannular patch being used most commonly in the hypoplastic annulus, and maybe a candidate for pulmonary wall replacement in the future. Obstructive regions, mild obstructions, no intervention needed. Balloon dilatation recommended for valvular PS more than 64 P gradient, valvular AS mean gradient more than 40. If ventricular dysfunction is present, immediate interventions are required in these regions. Single ventricle pathways, BT shunt with a in less than 6 months of age to augment the pulmonary blood flow in decreased flow situations. Glenn being done between 6 months to 12 months, and Fontaine in more than 2 years of age. This is a survival of children born with cyanotic CHD, unoperated. So most of the TGs will be losing by year's end if you are unable to operate. About 20% first 1 year survival. TAPVC will be around 18%. Hypoplastic left had more dismal outcomes, but only 10%. And top around 70%. Eisenmenger's heart-lung transplant remains the only surgical option, but you should counsel them regarding the disease, the physiology which is happening in the body. Avoid exertion, avoid going to high altitude, pregnancy is contraindicated, adequate hydration, iron folic acid supplementation, pulmonary vasodilators, and Bekele endocarditis prophylaxis. You can see a 3-month-old child here, large VSD showing cardiomegaly, pulmonary plethora with end-arterioles in the lung fields. And this is a 16-year-old VSD with Eisenmenger dilated central PAs with peripheral pruning with no cardiomegaly. So to summarize, when to intervene in congenital heart disease? Timely intervention is the rule for successful outcomes. Elective surgeries for ASDs, VSDs, PDA, coarctation of aorta, top, univentricular heart with PS. Early intervention for cases with severe failure to thrive, CHF, ventricular dysfunction, severe PH, severe cyanosis and hypoxia, pulmonary venous hypertension. And emergencies for obstructive TAPVC, critical ASPS, severe coarctation of aorta with LV dysfunction, duct-dependent circulations, TJ with intact septum. Quickly, I'll go through some of the interesting cases, and at the end, I'll take some questions. So this was a 9-year-old child with the history of breathless exertion, hyperdynamic apical impulse, echo showing a large muscular VSD. Here also you can see large mid-muscular VSD. A catheterization was done, showed room-air PVRI of 1.96. We took the child to Cath Lab, showing a large mid-muscular VSD, was closed through antegrade route through right interjugular venous access, showing closed with a muscular VSD device, showing both the disc holding, and a very good release. This was the post-procedure echo, showing device in situ, no residual shunts. Another case, a 1.5-year-old child with a history of cyanosis for 4 months, diagnosed to have heart disease, saturating 72. But echo showed a hypoplastic pulmonary annulus, hypoplastic range PS. We discussed with the surgeon. Surgeon was not keen for a full repair. He was saying for a shunt. We thought he's a candidate for RBOT stenting. You can see the preoperative echo showing a hypoplastic MP segment with a turbulence in the pulmonary artery. We took the child to Cath Lab, showing a severely hypoplastic MP segment. RAV showing stent being crossed over the wire. Stent was dilated, and a very good result was achieved. Saturations increased up to 85%. The child was followed up for a year, and after a year underwent a surgical repair. Echo also showing stent in C2 with good bolus seen across the branch PS. This was a recent case, 11-day-old newborn diagnosed to have CCHD on day 2 of life, shifted to us on PGI2 infusion. Echo showed pulmonary atresia with large VSD with duct-dependent pulmonary circulation. We took the child to Cath Lab. PDA was seen. This case, we planned to do it by a femoral vein route. And you can see the injection in the ascending aorta going through the femoral vein route. The wire was crossed into the PDA, O1 for coronary wire. Over the coronary wire, the stent was taken. Positions was confirmed through check angios. And finally, a very good result. Showing stent in C2, no obstruction to the arch, good flows to the branch PAs. Few surgical cases. This was a 3-month-old child, came from Iraq to us in CHF. Echo showed a large lobulated mass adhered to the ventricular septum and to the LV posterior wall. LVOT, there was no LVOT, LVOT was clean, but child had around moderate to severe MR, was in CHF. We did MRI. MRI showed a late gadolinium enhancement on MRI with mass adhered to the ventricular septum, most likely being cardiac fibroma. Postoperatively, most of the tumor mass was ejected with preservation of the papillary muscle. We had laminar inflow, mild MR, and the child went home uneventfully. This was a very difficult case we did last year. 6-month-old child, 3.7 kg, failure to thrive, cyanosis. Child present in severe sepsis with MODS, distal feeble pulses, allowed P2. X-ray showed cardiomegaly with pulmonary plethora. Echo was suggestive of a double out right ventricle with transpose physiology with increased pulmonary blood flow. And the arch was looking, seems to be interrupted. We did a CT to confirm our diagnosis. CT showed interrupted aortic arch, and you can see here, now it will come, the PDA is continuing as the descending aorta, and the arch was interrupted. The questions in front of us was, he was a very small child with a 3.7 kg weight, severe failure to thrive, option for bypass was very risky. And if you want to stent a PDA, the access was limited because of the low weight of the child. We found a hybrid procedure. So as you can see here, the arch is interrupted and the PDA is continuing as descending aorta, which was constricting. So we stented the PDA via the pulmonary artery post-anatomy to assure an restrictive supply to the descending aorta, and bilateral branch PA banding was done in the Cath Lab itself. These are the images. So surgeon gave us access by putting up a purse string through the MPA. We have gone across the PDA into the descending aorta, and the stent was deployed. Post-stenting, the surgeon banded it showed uninterrupted flow. The surgeon banded the bilateral branch PAs to achieve a target QPOQS of 1:1 with a gradient of around, we had achieved a 45 millimeters of mercury across the branch PAs. This was a PA sling, LP arising from right pulmonary artery, was a coursing behind trachea and causing tracheal compression. So LP was reimplanted into the MPA and a tracheoplasty was being done. Child was very good post-operatively. This was a recent pentalogy of ventral came with the absent sternum with pericardial defects, diaphragmatic defects, cardiac defects, and the absent anterior abdominal one. This case was done along with the plastic surgery team, and the child had a very uneventful course and went successfully. So this is our department at Max. We offer all the cardiology services of the pediatric cardiology, being the surgical or the interventional aspect. Looking forward to work with you all. Thank you.
Okay, thank you, Dr. Kumar. So we'll continue with few questions. Anybody? Dr. Ilan?
Thank you very much. It was really a nice presentation. I only have one question. You said VSD, you have surgical closure as well as device closure. So what's your experience on device-ly closed PM VSDs? Was there any conduction abnormalities in those patients who have device closure than those with surgical closure?
See, the good decision, it comes only by selecting the right candidates for device closures. So you should be sure enough that the defect is away from the aortic walls, not hitting any of the aortic walls. We usually go through a very good echo and a fluoroscopic guidance. Even after deployment also, we usually check in all the views. Is there any development of AR? If we are only sure that we have not touching of any of the walls, then only go ahead for release. So usually take up a margin of around 5 mm away from the aortic wall rim. And we usually measure the size of the discs as well. Okay, so if we are planning to use a 4-6 device, how much will be the disc size of the on the LV side? And we'll try to draw up a diagram on the echo probe only, echo image only, so that we can have an idea whether it will be impinging on the aortic walls or not. Only those in which we are sure about, then only go ahead for device closures. If we are little doubt also that the child may develop AR, we usually send them for surgery.
The question is the prevalence or your experience about heart block after perimembranous VSD device closure.
In my experience, I have seen 2 cases. One developed left bundle branch block, and one had a prolonged PR, which progressed to 2nd-degree heart block and required removal of device. So in my practice, I have seen 2.
Do you think it is heart block is higher in
heart block is higher in
femoral surgery?
Absolutely, heart block is higher in femoral VSD. It's a delicate area. We are working near the AV node, so child should be followed up. Should not, because most of these children after device closures they feel that now the device closure being done, no need to follow up. So, but should be followed up closely for rhythm issues.
Okay. Any other question? Any question? Any question? I have practical questions because I faced 2 cases with membranous pulmonary atresia with PDA. Since you didn't have the facility to extend the duct because it was progressively narrowing, babies were taken to OR for surgery. One of them was at around 18 days. The second was 32 days of age. Both of them opened the pulmonary valve and closed the duct. They couldn't come out of bypass. Then they tried to release the duct again. It was okay for a few minutes, but they couldn't come out of bypass. What do you think? Where is he wrong? On echocardiography, there was no clear coronary issue. There was no clear coronary issue on echocardiography. What do you think? And what do you recommend for the future if we face such cases?
Probably in that the PD was continued to remain open.
Sorry?
PDA was continued to remain open in that case?
Most of them were having, the first one, I was the one who saw 18 days old baby. Initially, it was 4 millimeter at birth. At around 16 days of age, I saw it around 2.53 millimeter. And we thought it is decreasing in size. And the baby was becoming a little bit critical. Since we didn't have the other option, we let the surgeon to operate. So where is the wrong decision and what we can learn from this?
In many of these children, if it's a membranous atresia only, but if the infundibulum is wide open, then going ahead with perforating the wall remains the very good option. But if the RVOT is a long segment atretic vessel and then you have tried, then usually don't give much better results.
What do you think? There was no infundibular issue, only the valvular, both of them were valvular.
But you
what
are
do you think?
unable to come out.
Why the surgeon couldn't bring the baby come out of this bypass?
Probably pulmonary regurgitation caused, I'm presuming.
Actually, I was not there in both of them. They say there was no pulmonary valve regurgitation. I couldn't explain it. There are certain from the surgeon.
The patient having pulmonary atresia, it is valvular, let's say, it's membranous type of atresia.
Yeah.
Good branch case,
Yeah.
no infundibular problem. MPA is okay, just only valvular atresia. You open the valve, then you see it. Definitely there will be pulmonary regurgitation. The issue, the problem is this extent of the acidosis, the hypoxic injury that they have been through, is not really, they are not in a position to come off bypass.
Yeah,
You don't
the
have,
RV was always being under stress throughout the fetal life.
Mm.
After even succumbing, these neonatal heart don't tolerate the pulmonary regurgitation very well. So they usually go into severe RV dysfunction and unable to come out.
it will be very difficult. That is the thing. It will get stunned.
I think the acidosis and the RV function will come down in most of the cases if there is pulmonary atresia. So since the reserve is minimal in those cases, so they will not come out of bypass. In this case, we have to be careful. If possible, we have to let the baby get time. Otherwise, it is very difficult. There is no time. The best option is stenting, yes? If there is a service, stent the duct. If there is no,
Any surgical intervention in that period will be having a longer morbidity and a higher mortality. As you are correctly pointing out, right candidates without having any LP origin stenosis, not a very tortuous PDA, should go for rectal stenting rather.
okay, the other question, you said in case of TGA intact septum, first prostaglandin infusion, then atrial septostomy, yes?
Actually, that was an advice for the cases being referred from a periphery, where we don't know what's the status of the PFO. So most of these children can benefit if you start the PDA is closing, the child is on day 3 of life. We don't know the status of the PDA. There's no harm in starting the prostaglandin infusion and then shifting the child.
Yeah, there is no harm. If whether it is PFO or larger ACD, you can go.
It won't cause harm.
Okay. 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 Thank you very much. So let's give our hand for Dr. Kaura. So Dr. Kefelegn takes the floor.
They have some questions still. They have one question.
Oh.
We can take it in the end.
So one of the question is, what is your experience on the effectiveness of paracetamol versus indomethacin or ibuprofen for pharmacological closure of duct in duct depending?
Our experience with paracetamol has been extensively very good. Okay. All
safe and effective.
Excellent results with paracetamol.
Okay. I think that is the burning question which you sent. Okay, thank you very much.
Okay, thank you, Dr. Ali and Dr. for extensive and to make it very beautiful part of cardiology. We're happy to have pediatric today. Otherwise, our friends have been killed us. Always adults. So the last but very important presentation, we'll have one more. It is Dr. Rajiv Agrawal from Max. He is very experienced adult cardiology. He did his MD and the DM from the famous IMS University. He had a very good experience and he did his intervention in US. So he has done in coronary, electrophysiology, and structural heart disease. So he will tell us advance in cardiac therapy. So I will give him a few minutes for that, and it will follow our dinner. Yes, sir. Time for you.
So thank you, sir, and really fascinated to see the extent of improvement in cardiology services and cardiac surgery. The questions are so incisive. So really, we have not flown down here to tell you how to do things. You people are doing pretty good. I came here in 2018, and I remember at that time I had given a talk on clinical cardiology. I talked about resistant hypertension, and the flavor of the conference was very different. But today I'm seeing that so much of active work is being done. You probably have the same problems that we have of a resource-poor country, and skepticism in the public, skepticism in referral doctors about the results. And yet, when you do have success, then the successes can be very, very rewarding. So Dr. Bekele showed those. Have we found it? My presentation is missing, it seems. Where is it? Advances in. Sorry. I can, yeah, absolutely. So the kind of pioneering work with Dr. Bekele showed about primary PCI and coronary interventions, it reminded me of the 90s in India, where in New Delhi in 85 or so, the first angioplasty was done. And in the 90s, when I had trained, so it was just the same flavor of being in a mission mode and trying to do these cases, and they were not available everywhere. But you have to keep at it, and you have to have small victories. The disease is so huge. You talked of a waiting list of 14,000. So there is no dearth of patients. Unfortunately, heart attack is the most common disease that we have to treat. And it's a question of winning all those battles in terms of public perception, perception of the referring physician, better pharmacology. I believe he talked about ticagrelor not being available in the country, better techniques in the Cath Lab, giving better results, and then moving from mission mode into systems of care. So for instance, in Max, now we have systems of care where if the patient comes to us with an acute myocardial infarction, even at midnight. So sir talked about somebody having an attack on the tennis court Sunday morning. That's easy. What happens at 2 a.m. when you have fog and even coming to the hospital is difficult. But even then, the standard of care is that you should complete your angioplasty within 1 hour. And if you don't, so there is the door to balloon time, door to needle time, everything is calculated, and there's a regular audit. And if you are not doing it in the right time, then there are things which have to be answered and why it did not happen. So that is what I mean by systems of care. And gradually you have to move from mission mode into systems of care. Still, in the hinterland, in the interiors of India, because India is a vast country, as I probably think your country also is, in the metros, this is the situation that 95% of patients coming to my hospital with acute myocardial infarction, not just ST elevation myocardial infarction, but also severe unstable angina where patient is unstable. These patients are to be taken up for primary angioplasty, and we are able to give excellent results. In the periphery, the availability of Cath Labs is poor, and so you have to calculate what is going to be the time it takes to transport the patient to an invasive center and do the angioplasty. You can add half an hour for transport, but if you cannot complete the angioplasty from the time of presentation within 90 minutes, including the time of transport across the traffic, then you should thrombolize the patient. And there are great improvements in thrombolysis also. We are not limited anymore to only streptokinase. There are second generation, third generation agents which give much better results. Streptokinase might give a 50% patency rate, stable TIMI3 flow in the coronary artery would be around 50%. But with the newer agents like tenecteplase and riteplase, alteplase, we are able to give patency rates of 70 to 80%. So we can do, if the door to balloon time is likely to be more than 90 minutes, thrombolize the patient, do a pharmaco-invasive procedure. So you have thrombolized the patient, some of those vessels will open, some of the microvascular dysfunction will reduce, then you live to fight another day. You can then transport the patient to the invasive center like my center in a much more stable state. And within 3 to 24 hours, you try to do the angioplasty of these patients. This is what is pharmacoinvasive strategy. So pharmacoinvasive strategy is when you do not have an on-site cath lab or you don't have on-site emergency cardiac services. The two things are different. You may have a cath lab. The cath lab functions only during working hours. Even then, you may want to thrombolize the patient because you have to save the patient's life and then transport the patient for an angioplasty and save lives. So this is what our scheme is. When the patient lands up in Max Hospital, 95% of the patients are getting a primary angioplasty. There are now certain government supports also. The economically weaker section patients do get some government support. So we are able to do that. And however, if the patient is coming to a peripheral center and he cannot reach the hospital in time, thrombolize the patient on the spot, transport the patient for a better angioplasty. Yet the disease is huge in our country, probably in your country also. The age of disease is going down. In any case, in India, and I don't know about Ethiopia, the average age of the patient with acute myocardial infarction is about 10 years less than the West. This also includes our lesser life expectancy. So in India, the average life expectancy is 70. In the West, it may be 80. I don't know what it is in your country. But to that extent, in the life cycle, you can expect the disease will be earlier. We have predilection with increasing urbanization, affluence, lack of exercise, smoking, etc., etc. So we are seeing younger and younger patients. Age is no bar to having an acute MI. And many of these younger patients have no collateral, so they are much sicker. Because the older patient, when he comes with an acute myocardial infarction, often there will be collaterals and you may get more time. In the younger patient, you usually are dealing with a big infarct. So anyway, so this is what it is. That presentation reminded me of what we were facing in the 90s. And so just like I think we have improved, although we have not yet caught up with, say, Europe or America in that regard. But I think the situation in your country will also improve from the few centers that were talked about, maybe many more centers, and much more public acceptance of acute myocardial infarction. So my job here today is not to talk of acute myocardial infarction. I would be talking of some of the other diseases that we have, and increasingly whatever can be done by non-invasive or less invasive means, that is in the cath lab, we try to do, and we leave the very sick patients for our cardiac surgeons who are doing such excellent work with almost keyhole surgery. But aortic stenosis is one such area where in the last decade or two, sea change has occurred. And aortic stenosis used to be predominantly rheumatic. The rheumatic heart disease has gone down quite a lot in our country, although it still exists, but it has now transformed into mostly a disease of aged individuals. And in these individuals, many of them have a lot of comorbidities. By the time the patient comes to us, the patient has so many comorbidities. Some are inoperable and some are very high risk, either because of heart failure, but more often because of kidney failure, chronic obstructive pulmonary disease, etc., etc. Earlier, this was like a life sentence. We know that we talk about 5, 3, 2 years. So once the patient of aortic stenosis is symptomatic, then if he has angina, then 50% death in 5 years. If he has syncope, 3 years. And if he has breathlessness with congestive heart failure, then 50% mortality within 2 years. So that is the natural history. And many of these patients, because of inoperable state or high risk, were just not getting operated, or they were getting operated at very high mortality. So we can now do the same procedure by percutaneous means. We can implant the same aortic valve, which the surgeons implant by the tissue valve. It can be crimped onto a catheter, no doubt a big catheter, and we can go mostly by the transfemoral route, but other routes also, and pass it up the aorta and into the aortic valve and give a very predictable result, which is almost equivalent to the cardiac surgeon today. So much so that now this procedure has been extended to moderate risk individuals and also lately to low risk individuals, so that many people would refuse to get cardiac surgery done for this indication. And so now in our hospital, about 10 to 15 TAVI procedures, that transcutaneous aortic valve implantation procedures, are being done every month, whereas this figure was much less even 2 years ago. So just like ASD is now, apart from the few cases which are sinus venosus or primum ASD, ASD is hardly ever going to the surgeon. So also aortic stenosis is gradually moving into the realm of the cath lab and less and less to the surgical domain. Anyway, I think we need not read all of this. I have already mentioned this. So whether you do this, sorry, where is the pointer? This one. Yeah. So whether you open the chest and put the valve with all the excellent surgical skills, which Dr. Sinha has shown, or you crimp this same valve onto the catheter and pass it in. And if you can do it, obviously, and the costs are also coming down. So obviously, we would prefer to do that. So I'll just show one or two cases of this regard. And in fact, the other issue here is cost. So cost is also coming down. There used to be only two manufacturers coming from USA with huge costs. Now, in India itself, there are valves available from 10 different companies, including Indian company. This My valve, which is being talked about here, is from an Indian company and at a much lower cost. And so the procedure is becoming predictable and also more affordable. So of course, first you have to do a detailed aortic aortogram and valve anatomy by a CT angiogram. And this is done by a protocol. This is an Indian cardiologist who is in Washington, actually. So his protocol is used all over the world. So this is one of the triumphs of this. So detailed measurements of at every level: ascending aorta, sinotubular junction, the height of the coronary arteries, the morphology of the aortic valve. Most crucially, that what is going to be your access route, because you will have to put a very big catheter, like a 14 French catheter, up the femoral artery. So there should be no obstruction. And if there is, then we have to either first dilate it or use a different route. So all of that is done. And then, so this is cross-sectional areas, you measure it. And then you must do a good puncture, because there's a big hole. You're making a hole of 14 French, which is like 4 to 5 millimeters in size in the femoral artery. Earlier, we used to call in the surgeon to the cath lab to do a surgical arteriotomy. No longer. We would take an angiogram from the other side, and then using a roadmap, we are able to puncture precisely, sometimes with ultrasound guidance, etc., etc. We use percutaneous closure devices, because for want of a nail, a kingdom was lost. So if you do a good aortic valve procedure and you end up with a huge hematoma or a retroperitoneal hematoma, you'll lose the patient. So every little step counts when you want to give good results to these patients. And we are operating at public expectation of better and better results and lesser tolerance of failure, which is good, because if we have to compete with the gold standard, which is the surgical technique, then we have to up our game. So it is, I think this is healthy competition. There are still cases where either they are young, low risk, no comorbidity, we would still send them to the surgeon. But otherwise, the high risk and inoperable patients are increasingly being done by this TAVI procedure. And I know of many super VIPs. There's the hospital where Dr. Sinha and I used to work earlier. The owner's wife, she had aortic stenosis, which was managed conservatively. This was 10 years ago. And if at that time TAVI had been done, that lady would have probably survived. One fine day, she had flash pulmonary edema. She was revived. Our cardiologist went in and saw her, and he comes out and he says her brain is cooked. And she was kept on ventilatory support by the family for a full 1 year in almost a vegetative state. And that thing could have been avoided if we had a stable TAVI program at that time. So these are the kind of stories, and no longer is it a procedure for the VIP. Now we are able to do it in people in lower middle class also, and sometimes if they have government support, now they are able to afford the valve. So you do it at various stages, and then you take an aortogram and see the level of the valve. You have a pacing catheter in place. This pacing catheter is used to give very high rate of pacing because you don't want your valve to move. You want very precise placement of the valve. If you placed it too high, it may slip out. Fortunately, that hardly ever happens. And if you place it too low, then the conduction system gets impinged and you have a high incidence of a requirement of pacemaker. So you have to place it exactly. So therefore, you do it under anesthesia. You will pace the ventricle at 180 to 200 in order to essentially achieve cardiac standstill for the few seconds when you are placing the valve. That can be done in other cases with degenerated mitral valve, but not in rheumatic valve. We still haven't reached there. You can do a mitra clip procedure in which the valve, which is basically degenerated and flaccid. So will it work now? And I'll run through this quickly. Okay. So we were here, we were showing this pacing lead. This is the test shot which was given. Then extra support pigtail wire placed in the ventricle. And on top of that, we would pass the, okay, here it is. And oh, wow, because it was running earlier. Anyway, so then we pass the valve. And so this is the valve which is going up the aorta. So it's a very heavy valve, and you have to pass it atraumatically, otherwise you'll end up with stroke. So sometimes cerebral protection is to be used, and then you pass the valve across the aortic valve. Sometimes pre-dilatation is required. So all these are steps. So as Dr. Gaurav had said, when to do, what to do, I think how to do, we can leave to the operators. When they come to us, we can discuss all those intricacies, because I think it's not so important as how to do. But here is the valve which is placed at the right position, some of it protruding out, and you have rapid pacing so that the ventricle is not moving and the valve does not get displaced. So then you get an excellent result. This is balloon expandable. And then later on, you close it with per-close sutures so that you don't end up with problem. And then you have multiple key outstanding issues. I think I'm already exceeding my time. Some of it I've talked about. So when should you go for tissue valve and when mechanical valve, when surgical valve, when TAVR, increasingly more TAVR, increasingly more tissue valve as the tissue valve becomes more predictable in its result. There's no anticoagulation there. And if it fails, then you can do a TAVR procedure later on. So therefore, increasingly, I think the space for percutaneous aortic valve replacement and tissue aortic valve replacement is increasing day by day. But we still have older procedures like the Ross procedure, where basically you are using the patient's own pulmonary valve So old tools are back in the toolbox. Aortic root enlargement or annulus enlargement. Sometimes the annulus is small, and what to do with that patient. So sometimes root enlargement has to be done, and that could be done surgically. There are some percutaneous means also. And so the multidisciplinary evaluation. Again, the other questions was asked was what to do with left main or complex disease. And so we have a heart team approach, because these questions are not to be answered by a single point answer or my way or the highway. So the cardiologist and the cardiac surgeon and the cardiac anesthetist, maybe radiologist now increasingly, even allied specialists like pulmonologists, etc., in terms of the risk, will sit down, will discuss, and a combined decision is taken that what is the best approach for the patient. That may be in valve cases, it may also be in left main and triple vessel disease cases. And then finally, of course, the patient also has a choice that if both procedures are possible, because many times there is a gray zone, then we can ask the patient to do that. So this is the self-expanding valve. At least half the cases are being done by self-expanding valve and the other half by balloon expandable valve. This is the Medtronic self-expanding valve. Earlier it was core valve, now it is Evolute Pro. And so similar, but there are differences. It would be placed a little more deeper, etc., etc. So this was the other procedure I was talking about, the transmitral valve replacement procedure in a degenerated prosthetic mitral valve. So here again, you do the same detailed anatomical analysis. The access route is not that much of a problem because you're going to go through the venous route here. So you are not that much bothered about the venous access, barring exceptions, of course. But you do want to do a very precise atrial septal puncture, because it must be a little bit more posterior and lower down in order to directly access the mitral valve. And you take the help not only of the fluoroscopy, but also of transesophageal echo. Sometimes you may puncture not in the thin fossa valis area, but lower down. And in that case, you might even use RF energy transmitted by your Brockenbrough needle in order to make that hole. And then that hole is dilated. So these are various steps. You are placing your catheter across into the septum. Then your guide wire is placed into the pulmonary vein. Over this, you will do balloon dilatation of the septum so that your catheter can go directly. A pigtail is placed into the ventricle. With that, you place a extra stiff wire, again pacing catheter. This is atrial septal dilatation. This is placement of the valve. And it may not be projecting very well, but you had the earlier valve ring also, which gave us a guide as to where to place it. So these are very rewarding procedures. The procedure where thoracotomy problems would take 2 weeks for the patient to resolve. Here the patient goes home in 2 days' time. And this is one of our patients, so did well. So those are some of the, so I have not shown a mitra clip case. There are many other cases, and our pediatric team is regularly doing VSDs. More and more VSDs are also being addressed by device closure. Though ASD, I think 90% is being done by device closure. VSD, much more selective. PDA is almost entirely in the interventional field, plus other things, vascular plug, etc. Well, what to do about pacing? Now, pacing, I think everybody's doing. And so you have a patient with LBB, history of syncope, and you want to give this patient nice narrow complexes, because you know that if you leave the patient in LBB, then if he already has some LV dysfunction, then the LV dysfunction will worsen. And if you do RV apical pacing, you will in fact cause pacing-induced LV dysfunction. So lately, in most cases, we are giving higher and higher cost solutions. This is a low-cost solution, actually, because you can achieve this by left bundle pacing. You basically will place the pacing lead on the right side of the septum, the upper aspect just below the AV node, and then actually screw it through to the left side of the septum. You've done properly, then you will capture the left bundle. The QRS narrows like in our patient, and the chances of LV dysfunction also go down. Sometimes this has been called the poor man's biventricular pacing in order to improve the ventricle. And this is then done at the cost of slightly more than the usual dual chamber pacemaker. So it is not a high cost solution. Unlike say TAVI, which still costs, we are costing the patient 3 times the cost what the surgeon is able to do the procedure at. But here you are doing it at a very cost-effective price. So this is the so you place various pacing electrophysiology catheters. This is at the AV node. You want to know where the AV node is. You have to go below the level of the AV node. Either you will do his bundle pacing, that's rather difficult. So left bundle pacing is upper septum. You place a specially shaped catheter and guide catheter, and the pacing lead, which has a screw, is then screwed through the septum. And here it is through the septum here, and it will pace the left side of the septum, and you will get a good result. This is the kind of lead that you have. So it's not much more costly as compared to this. So it just requires a little bit more training and a little bit more skill, but this is also becoming increasingly state of the art and does not take much more time and not much more cost. So these are some things. So you have to actually screw the catheter, and here is the lead. So earlier we used to do a full EP study, multiple catheters. Now we don't even do that. We know where we have to go. We just take the pacing catheter and it is screwed, and you look at a 12-lead ECG, see what the parameters are. This is what the lead is clearly across the septum. This thin line is the right side of the septum, and you have 1 centimeter into it, but you obviously don't want to perforate into the left ventricle. This is the right ventricle. This side is the left ventricle. You want to keep your screw just there, not through and through, and that gives you a good result. So here you are, and you then see it on echo also. Here is the lead on echo. So when done properly, and mostly now this is becoming predictable, this is also highly rewarding and quite interesting to do. Mitral balloon valvotomy is being done regularly here. And of course, there are difficult cases, difficult anatomy. And so there are many techniques. Sometimes when you maybe have not positioned your puncture, septal puncture properly, or the patient has difficult anatomy, you may have to do a reverse loop. I think it is not projecting very well, but the reverse loop really stabilizes it, and you are able to do the procedure in a better way with the reverse loop. Then the cardiac resynchronization therapy, which I talked about, the biventricular pacemaker. So a patient came with a big heart attack. We did the angioplasty, opened the vessel, but the muscle is already dead, or you have a dilated cardiomyopathy. So the patient is having heart failure, and you can, and especially with LVV, so you can place a lead not just in the right ventricle and right atrium, but also through the coronary sinus into a middle or posterior cardiac vein, and that will pace both the RV and the LV and cause a coordinated contraction. That would be cardiac resynchronization therapy. And if the right ventricular lead, it can also defibrillate, because these patients are prone to ventricular tachycardia, then it is called combo device. So this is a fairly common procedure, and in patients who are having heart failure, severe LV dysfunction, ejection fraction less than 35%, or less than 30% if they've had a previous myocardial infarction. QRS is broad, then CRT or CRTD is increasingly done. It is moderately expensive, but not prohibitively so in our setting. And so this is what the device looks like. And there are various guidelines which talk about it. Of course, when you reach refractory heart failure, then you have to have things like LVAD, which Dr. Sinha talked about, and transplant, all of which is being done. This I think Dr. Sinha has, and he has shown this case. We do have many other cases, but you know, this one we have ready access to in terms of the pictures. So coronary intervention, every coronary intervention is also not just put the wire, put the balloon, wham, bam, and you're done. Many cases have left main, chronic total occlusion, calcified vessels, diffuse disease, small vessel disease. In those cases, you need better imaging. You need intracoronary imaging and various things. Non-invasively, you need CT angio to plan the case. Then angiography is a two-dimensional appearance. So if you look at Mona Lisa, who's very dull here, slightly you can see her. Intravascular ultrasound using sound waves, you'll get a better image. And using light waves with OCT, you will get an even better image and resolution. And we are using both IVUS and OCT to get or either, not both, in many of our complex cases. So the question which was asked about left main. So many cases, as was pointed out, if their syntax score is low, they don't have too much other disease. Certainly an ostial left main today, I would not send to the surgeon. I would, with other vessels clean. So we have many stories here. Surgeon told us, this patient will die on the table. Patient says, I will give death on table consent. We did the procedure, patient is okay. Sung Jung Park from Korea, 15 years ago, he settled this question. If you have a low syntax score, then in the second decade of the 21st century, the patient should have PCI. But you should not do PCI unless you have the full armamentarium available. You should have all the drugs available, and which means not just clopidogrel, ticagrelor, prasugrel. 2B3A usage has gone down, but still it has to be available. And better coronary imaging techniques, including either IVUS and or OCT. And that does not add much time. It is not so expensive also, but it greatly improves the predictability of result in our complex cases. Plus, if the patient has calcific disease, you need to have the availability of rotablator. You need to have a technique called IVL, which uses sound waves. Same way as lithotripsy is done for the gallbladder and for kidney stones, the same miniaturized catheter is used in the coronary arteries to break those chunks of calcium. And then you can see the result by intravascular ultrasound or by OCT. And so you get a good result. So IVUS OCT optimization. So anyway, so this was one patient where I think I'll just go on here. Yeah, so this patient, post-bypass patient, of course, and the patient came with unstable angina and was dilated and stented in another center, but IVUS OCT was not used, so probably a suboptimal result was left. 6 months down the line, the patient comes to us with severe unstable angina and 90% stenosis in the ostium of the left main. So this time we did a procedure. We used IVUS, we used big catheters, and we know by the experience of IVUS and OCT that what you see on angiography may underestimate the size of the vessel. So you have to cautiously overdilate these vessels, but stay within the limit that you don't rupture the vessel, and then document that you have a good result by using IVUS and OCT. So this is what we did. Procedure itself is simple, and the patient is okay 2 years down the line. And then this is the OCT. So here you are seeing cross-section at various levels, and I think this is going very slowly. But anyway, the stent is far ahead. So we ended up doing an plain balloon angioplasty without putting an extra stent in this patient. So this is it, that if you actually know what you are doing, you don't have to always put stent within stent. Often you do end up doing that, but you can do it as per the need. There are many cases where we are able to use drug-coated balloon, because if you, in a small vessel, you have a stent, you put another stent inside it, you don't have any space left. And we can use drug-coated balloon. We can decalcify, see the result of the decalcification, and do these procedures. So if you're going to do complex work, then you should have intracoronary imaging available. So there are many other things, and I think we are at the end of our attention span. So although this literary reference has some bad connotations, but it is indeed a brave new world. And this was, of course, Aldous Huxley long ago, and they were talking of a bad world. I have many other cases to show, but the Max STEMI program. So, but the brave new world, we should not be scared. So this is one of our left main cases where the patient had to be intubated and defibrillated, but then we got a great result. Of course, we all have these examples, but we have to keep pushing the envelope, and we have to stay within the realm of the possible. The realm of the possible would probably be different in Addis Ababa. I think you are at a stage where maybe we were, not to be patronizing, but in the early 2000s. So just like we are still catching up with the West in many ways, especially in systems of care. So also, I think with increasing availability of Cath Lab techniques, financial support from government, public confidence, skills, these procedures will become, what has been heroic will become standard. And we are happy to collaborate with anybody who wants to come and spend time with us and train with us. And we would learn from your experience and vice versa. So thank you for your time.
Thank you, sir. It's very stimulating and taking us to the next level of cardiac service. If you have a question, you will think over it. And I have some question. In our setup, coronary, we are becoming better in coronary workup. Left main, okay, bifurcation. Calcium, difficult, we don't have OCT, we don't have rota. So still we are in the black Mona Lisa. So we need that improvement. Structural, mitral, okay, that's good. We are doing good mitral valvotomy, including difficult cases like extracorporeal, very calcified, even Luton butchers. TAVI, me and my friend, Dr. Seifu, has a chance to go Valvular on my valve, sponsoring us. Thank you for that. But the TAVI, I think it needs good multidisciplinary, I said, vascular surgeon, do good CT scan, and our surgeons. But I think we have to hope for that and come to that, and you will help us. That's important to fill our gap. That's important. My question, in that patient with mitral valve, who have tissue valve, now putting percutaneous, what valve you are using? The same? Okay, opposite. Thank you. One more, because I'm the moderator and the boss. I'll have a chance. In his bundle pacing, to have narrow QRS, where we don't have EP study, and we also don't have the sheaths, do you suggest us doing with fluoroscopy, at least to make more septal positioning of the RV lead without, we don't have EP, at least we have one center in EP, but not weight grown. We are still using fluoroscopy for a pacemaker. We say to be septal, may not be real.
See, you know, there are many things available. There's always an option to send the patient out for, there is not that much tolerance to doing a shoddy procedure. So if a procedure is available and if there is state of art, which says that it can be done in a certain way, then either we do the low-tech conventional technique, or if we do it do it with the more advanced technique, then we should do it properly. So initially, the LBB pacing was done with the full EP catheters in place. We used to put the his bundle, you know, catheter, know where it is, come a little bit lower and to the right. Then you have a 12-lead ECG. You see the change in the morphology in 12-lead ECG, calculate ventricular activation time. Nowadays, with that experience, we are able to make the procedure simpler. But that is on the back of the experience that is there. So I think the initial cases should be done either with a proctor or and at least the 12-lead ECG. So with the proctor and 12-lead ECG, it can be done easily. I didn't show leadless pacemaker. There are many other things which we can do, because even if you do an advanced procedure in this country, like the same thing happens when we compare ourselves to the West and India. So it is not tolerable to do a shoddy procedure. So if you do it, then sometimes initial experience, even with TAVI, used to call in proctors from America, and they would come because the procedure was fairly straightforward, but it is very daunting to do it. But nowadays it is becoming pretty much simple. And the LVP pacing is also something which, after the first few cases, I think experienced operators like you would pick it up very easily.
Thank you, sir. Now, chance for audience. And I think this is on your table. You can scan it for registration. So if there is no question, okay, let's give him very hand for everybody. And I would like to thank all presenters coming from India, giving us very nice experience sharing, and our audience, very important Saturday, waiting in the afternoon. And we'll have a dinner. Hilton has very delicious dinner, so we'll join that. And I will thank Max Health and Yetena Weg for cooperating with us. I hope we will continue with the same and we'll collaborate. Thank you very much.